The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, we're going to get started. Thank you all for logging on for this important webinar on the USAID Nutrition Strategy, Integrating WASH and Nutrition Programming. We, WASH Advocates in 1,000 Days, are excited to be hosting 3 excellent panelists who are going to be talking to us about the importance of WASH and nutrition and how this is playing out at USAID in the nutrition strategy, the proposed pathways between WASH and nutrition, and how this new strategy will impact integration of WASH and nutrition. Our panelists include Dr. Helen Petach of USAID, Tom Davis from Feed the Children, and Smita Baruah of Save the Children. Dr. Helen Petach is an environmental health technical advisor for the Bureau of Global Health at the United States Agency for International Development. She provides support for health programs in water, sanitation, indoor air pollution, and other aspects of maternal and child health, with a particular focus on fostering partnerships and ensuring evidence-based approaches. Dr. Petach earned a PhD in chemistry from Cornell University and developed diagnostic technologies for disease and measurement of water quality in both the private and public sectors. Tom Davis is the Chief Program Officer for Feed the Children. Tom has 30 years of domestic and international field experience in planning, implementing, and evaluating MCHN and social and behavioral change activities in 25 countries. He was the 2012 recipient of the APHA Gordon Wyan Award for Excellence in Community-Oriented Public Health, Epidemiology, and Practice. And Smita Baruah is the Director of Global Health Policy and Advocacy at Save the Children USA, and is focused on maternal and child health and nutrition issues. Prior to SAVE, Smita was Director of Government Relations at the Global Health Council, working across global health issues, and led on appropriations advocacy at Interaction. So some housekeeping items before we begin with our presentation. Since we have a large group here, we will be only taking questions through the question box that should be on the right-hand side of your screen. If we do not get to your question during the webinar today, we will be providing the questions to the panelists, and we'll be sending out their answers to those questions after the webinar. We will also be recording the session, and it will be available for those who either want to refer back or who weren't able to attend. It will be available to view. And with that, let's get started with our presentation. Dr. Petach will be talking to us first. So Helen, whenever you're ready.
Thank you, Jordan, and welcome everyone, and thank you very much for joining us today. I just wanted to set the stage for the timing here. USAID launched its water and development strategy almost a year ago, and USAID launched the Multi-Sectoral Nutrition Strategy about a month ago in May 2014. And this is an opportunity to discuss the linkages between those two sectors, water and WASH programs and nutrition. Next slide. So to provide a little bit of background, USAID has a long nutrition legacy. For over 50 years, USAID has been a leader in international efforts to improve nutritional status in developing countries. And here's a list of some of the historic programs that USAID has been involved in, some continuing through to today. Food for Peace started in the 1950s, moving forward all the way to social and behavior change communications that started in the 1970s, and those programs continue today. As you know, we still experience global nutritional challenges. Next slide. So this data comes from the CHIRG, the Child Health Epidemiology Research Group, and it's data that's well known, and it shows that diarrheal disease causes 9% of all child deaths, totaling 600,000 deaths annually. Undernutrition, though, underlies 45% of all child deaths, and is a significant player in this graph, the causes of child death. I want to bring out a couple of other important numbers. Pneumonia is the largest single cause of death at 17%. It's also related to WASH practices. So WASH and nutrition practices are of key importance for reducing preventable child deaths. Next slide. So let's transition here to discuss the types of undernutrition and the tolls that they take. Acute malnutrition, as manifested as wasting is low weight for height, is caused by the reduced intake of nutrition, and it leads to 1 million child deaths annually. It afflicts 52 million children each year. A second type of undernutrition that we'll describe is chronic undernutrition. It manifests itself as stunting. Stunting afflicts over 160 million children a year. Stunting is low height for age. And what we found in recent research is that 25% of that stunting is attributed to having 5 or more episodes of diarrhea in a child's first 2 years. Next slide. So what causes this undernutrition? There's a whole variety of issues that affect undernutrition, but one of those is diarrheal disease. A vicious cycle exists between diarrhea and undernutrition. Children with diarrhea eat less and they're less able to absorb nutrients from their food. But at the same time, they need additional calories to be able to recover from their infections. But malnourished children have weakened immunity and then become more susceptible to diarrhea when they're exposed to fecal material from their environment. Evidence shows that interventions for improving the quantity and quality of domestic water supply, ensuring the use of improved sanitation and safe hygiene practices can reduce this diarrheal prevalence by 1/3 or more. We now know that WASH interventions have an immense impact on diarrheal disease. But diarrhea might only be the tip of the iceberg in how WASH affects growth, and Tom will be talking about a number of other aspects in just a few minutes. Next slide. So the USAID strategies include discussions about water and nutrition. The USAID Water and Development Strategy emphasizes links between WASH, nutrition, and food security. In countries that are off track to meet the MDG for sanitation, and where diarrheal disease and undernutrition are prevalent, missions must add sanitation programming. And where diarrheal disease and undernutrition are prevalent, these combinations of sanitation and hygiene become particularly important. Switching over to the USAID Multi-Sectoral Nutrition Strategy also emphasizes the relevance of WASH to nutrition. This strategy calls on USAID to increase access to high-quality nutrition-sensitive services. Those services include access to water, sanitation facilities, hygiene, and so on. And USAID is further committed to making its nutrition initiatives more effective by integrating key hygiene actions as essential components of all nutrition programs. So here in this next slide is a description of some of those high-impact actions that are described in the multi-sectoral nutrition strategy. And the one I'd like to pay particular attention to is the red box, including integrating key WASH actions, as that is of critical importance to our discussion today. Next slide. Can we forward one more slide? So I just want to alert you to a place where you might be interested in participating. And that is a community of practice that we formed collectively with a variety of different organizations. It's an open structure. It's not a USAID internal community, called the Nexus of WASH, Nutrition, and Food Security. The goal of this program is to encourage discussion around the integrated programs in WASH, Nutrition, and Food Security, and host articles and announcements and webinars on recent results and program results. If you're interested in joining, I'd recommend that you contact Dan Campbell. His email address is shown here on this slide. And it's an opportunity to discuss a variety of programmatic activities in WASH and nutrition. At this point, I'd like to switch over to discussing a couple of programs that show particularly intriguing results in integrating WASH and nutrition programs. The first of those is the Shuhada project. Shuhada was a project which stood for Strengthening Household Ability to Respond to Development Opportunities. It took place in Bangladesh from 2006 to 2010. And it included a package of interventions for incorporating WASH and increasing access to nutrition, including some Title II food rations for young children and pregnant and lactating women. What was special about this was by integrating both WASH and nutrition, a variety of different outcomes were achieved. First, the dietary diversity score was increased by 26%. Access to safe water was increased from 57 to 72%. And access to improved sanitation increased from 14 to 55%. So those are discussions more about access. But in looking at specific outcomes, we found that stunting was decreased from 56 to 40% in the critical group from 6 to 24 months. So this is one example of a program that's actually been in operation that shows tangible results from integrating WASH and nutrition actions in the same program. I'd like to continue to another case study. Next slide. This study is called the Good Start Program. It took place in Peru from 1999 to 2004. And it was based on participatory community-based programs that integrated nutrition, WASH, and in this case, early child development, another very important component. It took place in the Andean highlands, and it combined a little bit of community participation with capacity building. And primary interventions included things like prenatal visits, nutrition during pregnancy, inclusion of the husband in support of breastfeeding, consuming iodized salt, and so on, and a variety of different WASH interventions. And again, perhaps the most important part of this are the outcomes that were achieved. Stunting was decreased from 54 to 37%, and anemia prevalence dropped from 76 to 52%. Again, very interesting results from a combined WASH and nutrition program. So I'd like to close in the last slide and just give you a thought, and I think this will transition to Tom Davis's discussion, that there are many ways in which WASH and nutrition programming together could affect nutritional outcomes. And what we believe we see evidence for is WASH is important for reducing diarrheal and other infectious disease, reducing parasitic infections, including worms, and reducing the pathogenic environments that lead to gut dysfunction and environmental enteropathy, which we'll talk much more about. And I just want to leave you with one very important outcome. The Lancet carried out a series in 2013 to consider nutrition. And one of the most important outcomes, I think, from that discussion was that if the 11 key nutrition interventions that were described in this nutrition series were scaled up to 90% coverage, which is ambitious, stunting would only be reduced by 20%. So nutrition alone cannot be the answer. And at this point, I would like to transition to Tom Davis, as I think he has some very insightful things to say about that. Thank you for your attention.
Thanks, Helen. I am Tom Davis, Chief Program Officer with Feed the Children. If you haven't heard about Feed the Children lately, please check out our new webpage. We're undergoing a very substantial transformation. So stunting is our white whale. This is something we've been after for a long time. We have not made this sort of strides in it that we have with other things. While we've been able to make incredible improvements in lowering the child death rate, no large-scale intervention trial has ever normalized child growth, despite everything we have thrown at it. We need to pay attention to the interventions that we know help, of course, but we also need to be testing out new interventions like reduction in maternal depression and confronting environmental enteropathy that may lead to substantial further reductions in stunting. So we've talked a bit about diarrhea, but as Helen mentioned, diarrhea may just be the tip of the iceberg in terms of how poor water, sanitation, and hygiene affects the growth and health of children. Some studies have shown decreases in diarrhea while child growth really didn't change at all. And because of this assumption that diarrhea was the main way that WASH affects growth, the Lancet probably underestimated back in 2008 the effect of WASH on undernutrition, expecting only a 2.4% improvement in nutrition from 99% coverage with WASH, since it was modeled almost entirely through clinical diarrhea incidents. However, we now know that most of WASH's effects on linear growth is independent of its effect on diarrhea. It's probably mostly from this environmental enteropathy. Also, we can't just look at the impact of WASH on diarrhea. We need to look at its impact on stunting, cognitive defects, child mortality, and even a 50% reduction in the incidence of pneumonia from hand washing with soap. And if anyone needs to see that randomized trial, it was in the Lancet, I could share it with you. But just focusing on stunting in several studies, they found 5 to 20% of linear growth deficit was attributable to diarrhea. Next slide. So now, the latest point of focus is understanding and improving child growth for good reasons is environmental enteropathy. If you've ever seen slides of a cross-section of normal intestines, it would look something like this image on the left. There are plenty of nooks and valleys like the fjords of Norway. And by having these nooks and valleys, you can increase the overall surface area of the intestine for absorption. But with environmental enteropathy, the intestinal wall can look a lot more like this image on the right, flatter, not as many nooks and crannies. And with environmental enteropathy, there's a change in morphology of the gut. You see both reduced surface area, and it can become more permeable, letting more microbes in. I once tried to calculate the total surface area of an infant's small intestine, and it looked to be about 340 square feet. That's compared to about 2,000 to 2,500 square feet in an adult's intestine. And in 1 square inch of small intestine, there are about 10 billion microvilli. And I'm not sure of the amount of reduction in surface area with environmental enteropathy, but it's quite significant. And if you took that same length of intestine of an infant, and if it was smooth as a PVC pipe without any of the villi and microvilli and other features there, it would only have about 1 square foot of surface area. So more than 300 square feet with all those microvilli and the way it's built, and only 1 if you had none of that. Also, that lining is only 1 cell thick, and environmental enteropathy can cause that wall to break down in places, allowing more pathogens to get inside the body. So you can see increased intestinal inflammation and permeability, which then leads to chronic immune activation. So as the immune response in the body is triggered, the body will shift away from growth as it focuses more of its resources on protection. And having a bunch of pathogens breaking through the intestinal wall on a regular basis is a good way to get the body to deprioritize growth and focus on fighting all those microbes that are breaking through the gut wall. So remember that there are 2 problems here: pathology of the gut and profound derangement of the child's immune system. Next slide. So EE is caused by chronic exposure to fecal bacteria in areas lacking sanitation and hygienic conditions. And we now know, that environmental contamination causes growth faltering mediated through this environmental enteropathy. And specifically, chronic immune activation leads to decrease in growth factor and poor absorption, which leads to stunting, and an increased hepcidin, which leads to anemia. So you see both problems, growth faltering and anemia from this. So, next slide. Why does this matter? Well, we know that improved wash is associated with an increase of about 0.1 to 0.6 height for age Z-score, about the same effect size as the very best infant feeding interventions. And I remember the first time I heard this, I was amazed but a bit skeptical. It didn't fit with what I'd always heard about WASH, and I considered WASH very much in the back seat in terms of lowering stunting. And now we're learning that we need to give a lot more focus to WASH than we used to if we want to do something about stunting. So we're not just saying that, yes, we need to do some WASH with nutrition. We're saying we need to do a lot more WASH if we're going to see the sort of results that can possibly reverse this problem with environmental enteropathy. And possibly not just stunting. This study mentioned that in areas with poor sanitation, children experience vicious cycles of environmental enteropathy, and emerging evidence is linking early child diarrhea and or growth failure with an increased occurrence of risk factors for cardiovascular disease in later life. So even after they survive, it can cause problems in later life. This could be important to the dual nutritional problems that we increasingly are seeing in some countries. Next slide. So this colorful wheel shows some of the most common taxonomic groups of bacteria in the gut. There are a lot of them. Now your brain weighs about 3 pounds, right? You may be surprised to know that you are, by weight, about the same amount bacteria as you are brains. No offense. Collectively, all the bacteria in your body weigh about 3 pounds, and there are trillions of them and only one of you. So the San Diego Zoo has about 797 species, click, that you can see there. If you want to go to the San Diego Zoo, you can see the 797 animals they have. Please click. But if you want to see more, you're a much bigger zoo, representing 10,001 distinct species, 10,000 bacteria, and the one other species, you. This invisible zoo living on and inside you is way more diverse and complex than any other zoo. And we're learning that this microbiome that exists is very important. How we pull in nutrients, all sorts of things. Some really emerging evidence is coming out on that. And if you want to learn more about that, you could read a book by Jay Martin, Missing Microbes. Excellent book that starts talking about some of this research. Next slide. Now, this series of box plots, I'll wait for that to show, okay, shows how some bacteria are found more often in the gut of children who are severely malnourished, the ones that say SM, the red boxes, while others are more likely to be found in the gut of apparently healthy children. And this may mean that it's not just a matter of children getting more pathogenic bacteria in their gut when they're malnourished, but they are losing the good bacteria that they need. For example, there are certain good bacteria that help us to anaerobically ferment dietary fiber and resistant starch into short-chain fatty acids, and they do that in the colon. But if you take mice and inject their gut with the microbes that are in the gut of a third trimester woman, those mice will gain more weight and have higher blood sugar levels compared to mice that have received microbes from first trimester women. So this microbiome changes during different times, and they're very important in terms of what's happening in our gut. So we're finding that what we're finding is that these microbes that live in our gut help us to do many things, and if we kill off the good ones, it can change our metabolism in negative ways. And if we kill off the bad ones, it can change our metabolism in positive ways. And in reality, there are not as much good ones and bad ones, but rather having the proper mix is the important thing. For example, many of us, if we were to all go in right now and be tested for strep throat, a lot of us would find we have strep throat in our throats, but the presence of strep doesn't mean that you necessarily have a problem. It's the abundance of them that can make the difference. There's some exciting research being done around these microbiomes of bacteria that live in us, or maybe we should say that we live in them, since all of the cells in your body, of all the cells, only 10% of those are human. The other 90% of the cells in your body are bacterial. And if that just blew your mind, well, join the club. That fact really blew my mind when I was reading through this book as well, to realize that 90% of what I'm considering me in terms of my cells are actually bacterial. So this is an important area that we're learning more and more about. Next slide. So this probably helps answer the question that might have been coming to your mind. What about just using more microbes? If you're wondering why we don't just regularly dose all children with antibiotics to kill off the bacteria and get rid of environmental enteropathy and improve growth, like we do with farm animals in the United States, for example. We do that to help them grow, give them antibiotics. It's outlawed in Europe. You have to remember that there are quite a lot of good guys in your gut that you could wipe out in the process. There's also recent research linking the use of antibiotics with child obesity in the U.S. So we need to be careful about how we approach this problem. Restoring a clean and healthy but not necessarily sterile environment is probably the most prudent approach. We might be hearing a lot more about the use of probiotics as a therapy at some point. If you want to keep up with some of those latest findings, there's whole websites around microbiomes and some of the research that's being done on that. And also there's the problem of increasing antibiotic superbugs, of course, as well, if we started using antibiotics more liberally. Next. So if you still need more convincing that we need to do more in terms of WASH to reduce stunting, one of the best places to go to find out what truly works is the Cochrane reviews, which are available online. And a recent Cochrane review found a benefit on linear child growth, specifically from solar disinfection of water, provision of soap, and improvement of water quality. So we know that these two are linked, improving WASH and improved linear child growth. We also know that unhygienic conditions may contribute to decreased early childhood development through environmental enteropathy. So if one of your main concerns is ECD, this also can help with that. Next. So what are we doing about environmental enteropathy? It's clear that it's time to test out more interventions that can decrease unsanitary conditions and further explore this linkage with infant nutrition and growth. And many practitioners are doing just that. One example is the SHINE studies in Zimbabwe. And they're testing the hypothesis that making major changes to WASH can lower environmental enteropathy and in turn lower child stunting and anemia. So in SHINE, they're testing standard care, basically reinforcing the community health workers, doing exclusive breastfeeding promotion, testing that against nutrition alone interventions, which includes giving 20 grams of NutriButter daily to kids 6 to 18 months old, versus WASH alone, versus nutrition, plus WASH. So in that way, they're hoping to kind of sort out what seems to make the most difference. And for WASH, what they're promoting is VIP latrines, tippy taps, soap, hand washing with soap, water guard, and a protected play area, which is kind of a new area for us. How do we assure that kids are developing cognitively well and yet give them a very safe place that's probably going to be enclosed, but a safe place to play so they're not coming into contact with human and animal feces. And the preliminary outcomes are expected in December 2015, but you probably won't see anything published on that to around December of 2016. There's also the WASH benefit study in Bangladesh and Kenya, and they're measuring the impact of WASH and nutritional interventions during the first 2 years of life. Lastly, there's also the Maladi studies, that's how they pronounce that. Those are underway in 8 different international field sites. And the hypothesis being addressed in those studies are that infection with specific enteropathogens leads to malnutrition by causing intestinal inflammation and or altering the barrier and absorptive functions of the gut. And also looking at a hypothesis that the combination of enteric infections and malnutrition results in growth and cognitive impairments in young children, and that may lead also to impaired immunity as measured by responses to childhood vaccines. So there are a lot of studies in progress concerning environmental enteropathy, but in the meantime, given the other benefits of WASH, I know that we in Feed the Children are bumping up WASH up that priority list as a means to decrease stunting, and I hope that you'll be able to do the same. If you want to learn a bit more about this, you can also see I've got a link here to another webinar specifically on environmental enteropathy that's on the FSN Network website. Thank you very much.
Hi everyone, this is Smita Baruah with Save the Children, and I'm going to take us back a little bit to the strategy and also take a different angle. We've heard about programming and the scientific evidence behind why we need to integrate WASH and nutrition interventions and the importance of WASH and its impact on addressing undernutrition in children. But the USAID nutrition strategy didn't happen overnight, and nor did it happen by accident. It actually it was a result of a nearly 18-month advocacy, probably longer than that Save the Children co-led with 1,000 Days, Bread for the World, and many other organizations. So we've heard about this a little bit about the why we need to improve malnutrition. Just a little bit on the consequences of undernutrition. It is the underlying cause of 45% of all under 5 deaths, contributing to 3.1 million deaths of children each year. It impacts cognitive skills, lower IQ and school performance, as well as it impacts the ability of the child to thrive. And as you'll see there, the economic impact, it costs countries 3 to 6% of GDP. So, you know, nutrition is not just important for improving the health of children, but it also has consequences on a children's ability to learn and thrive. Next slide, please. So we I would say about 2 years ago, even before, or I guess just after the World Health Assembly nutrition targets were passed in a resolution in May 2012, the NGO community, particularly in Washington, was advocating for more increased U.S. government leadership and commitment to nutrition. And we had we had 3 advocacy asks. One was to develop a whole-of-government multi-sectoral nutrition strategy, as that would give us a better idea and a more transparent idea of how across programs U.S. government is contributing to improving nutrition, as well as giving us a sense of a more comprehensive budget. And so we asked for a more transparent and comprehensive budget data on how much the U.S. government is spending on nutrition. And then we asked for targets. As I said, the World Health Assembly passed a resolution in May 2012 with 6 nutrition targets. And our hope was that the U.S. strategy would outline how it's contributing to those targets. In June 2013, we again reiterated our call for a strategy, and particularly a stunting target, to be announced at the London Nutrition for Growth meeting, as well as the comprehensive budget again. And within that, we also wanted to build on U.S.'s leadership. In September 2010, Hillary Clinton and the Irish Foreign Minister announced the launch of the 1,000 Days Initiative. We wanted a renewal of the commitment of U.S. government's 1,000 Days Initiative, and recognizing throughout the strategy and all of its work the importance of focusing on the period from pregnancy to age 2. This was, of course, helped and built upon the Lancet Maternal and Child Nutrition series that was released just before the London meeting, that again codified both the importance of nutrition-specific interventions, but what this series also did was bring in the importance of the multi-sectoral approach, and specifically also talked about nutrition-sensitive interventions such as WASH. Next slide. So 1991 was last when USAID Nutrition Strategy was released. In September 2013, following the Nutrition for Growth event, USAID started writing its nutrition strategy. We all commented on a draft in December, and then in May 2014, the strategy was launched. Next slide. There was a process before USAID put pen to paper in September 2013. We had a first consultation in July of last year, where the NGO community at least came together first and provided comment to the outline that USAID presented on what should be in the nutrition strategy. We also wanted to make sure that the feedback does not only take place in Washington. So Save the Children helped facilitate the distribution of a survey that went to all of representatives in the field, NGO representatives, as well as they sent the same one to all of their mission directors, USAID mission directors, and took feedback on the survey, which went through, as a 5-question survey that again looked for feedback on what needs to be in the strategy. And a lot of what came up in that feedback was civil society consultation, increasing nutrition capacity in the field, not just in Washington, clear benchmarks, targets, and so on and so forth. And so that was part of the consultative meetings that they had with implementing partners, CSOs, and other donors in host countries. And then there's also, they developed technical and operational guidance for field missions. And we're hoping that the implementation of strategy will also include expanded technical support to countries, both financial and monitoring and evaluation. Next slide, please. when the community put together their recommendations on a multi-sectoral strategy, what we really wanted to lay out there was that nutrition was not just a health issue, but that nutrition was a development issue. And so we wanted, the strategy to specifically look at how are nutrition interventions being integrated in other development sectors, and the way WASH has been highlighted in the nutrition strategy is certainly one way that we had hoped nutrition interventions would be integrated with other development sectors. And then we also wanted the strategy to specifically identify both nutrition-specific and nutrition-sensitive. And I talked a little bit about that earlier, what that means. Next slide. So water and nutrition, what are the links? I think we've already heard from others, but certainly from Helen's slide as well as Tom's slide on the linkage between water and nutrition. And I think just to kind of emphasize that, we know that lack of safe water close to home has many indirect effects. People are often left with no choice but to drink unsafe water from unprotected sources, and the end result is many of the childhood diseases that we hear of, such as diarrhea. And the constant presence of diarrhea can significantly contribute to undernutrition. And so USAID nutrition strategy is an opportunity to link the direct nutrition interventions with water and sanitation and hygiene activities under this one coherent framework, and I think that's what, and it does that well. Next slide. This is just saying what the aim of the strategy is to guide the agency's policies and programs for nutrition in both emergency and development contexts, with the goal of improving nutrition to save lives, build resilience, increase economic productivity, and advance development. For the policy advocacy community, the aim of the strategy is also to show Congress, particularly, a very specific way of how nutrition funding is being spent. And so this USAID nutrition strategy, it does pull that out and talks about the various interventions in nutrition specific and nutrition sensitive. And so for us, it goes beyond just guiding the agency's policies and programs, but for us it is also something to refer back to and show our key stakeholders, primarily Congress, on what USAID's framework and approach is to improving nutrition, with the end result being that resources will continue for nutrition. Next slide. Next slide, please. Great. So as I said, the NGO community had specifically asked for links to the World Health Assembly 6 nutrition targets. The strategy does include 2 targets. One is a goal to reduce stunting among 2 million children over the next 5 years. And this is through both U.S. government's Feed the Future and Global Health Initiatives, and through the Office of Food for Peace Development Programs, resilience efforts, and other nutrition investments. And so we're very, very happy and pleased that this stunting target is in there. And then they also added a goal to mitigate increases in acute malnutrition, with the goal of maintaining global acute malnutrition below the emergency threshold of 15%. Next slide. And so what does the USAID strategy do? The USAID strategy does emphasize nutrition-sensitive interventions, including agriculture and WASH activities. It also recognizes the vicious cycle between undernutrition and WASH-related diseases. We've already heard of the environmental piece, and I've already talked about the diarrhea piece of this. And then it also emphasizes the importance of both getting calories and nutrients into young bodies through nutrition interventions and keeping those calories and nutrients in so that may be absorbed and utilized. Next slide, please. Sample activities, I wanted to just highlight some of the activities that the strategy includes, like how are they doing this, how are they integrating WASH and nutrition activities. And these are some of the sample activities that they mentioned in the strategy. Promote and facilitate increased access to and use of safe water supply and key hygiene practices. Jointly promote essential WASH, food, environmental hygiene, and nutrition actions in community. They are also looking at behavior change interventions such as hygiene practices, that includes hand washing, and also looking at improving water systems. Next slide. So, we're very pleased as a community on the USAID nutrition strategy and want to congratulate our USAID colleagues on it. It definitely is a multi-sectoral strategy. It emphasizes the 1,000 days window of opportunity from pregnancy to the age of 2. It emphasizes stunting, and it definitely emphasizes other indirect interventions such as WASH. And we're now focusing on the whole of government nutrition coordination plan and hope that it expands upon the great work that USAID has already done on its specific nutrition strategy, and also hoping that the budget funding that explains what funding is used for these nutrition-specific and nutrition-sensitive interventions will also be made publicly very soon. So, thank you.
Great. Thanks, Smita, Tom, and Helen for those great presentations. We're all very excited about the new nutrition strategy and eager to see how it can be integrated into what's already going on in the field. So we're going to open it up to questions now. So if any participants have questions, please type them in the question box on the right-hand side of your screen. If we don't get to all of the questions in the time we have left, we will be sending those remaining questions to our panelists and sending out their answers after the webinar. Our first question that we have is, what is a good proxy indicator to measure changes in environmental enteropathy prevalence in a nutrition-sensitive WASH project? So I'm not sure if Tom or Helen, you want to take this one?
Well, I could. There is some emerging things coming out where there was a study done by Margaret Kosek where she was looking at some of the different enzyme-linked immunosorbent assays. They've got several different types of these that are really not that difficult to use. It's basically a feces test, though, but where they linked that having positive outcomes on these different assays were very much linked to growth, and they believe that was because of environmental neuropathy. It's not something that otherwise I think is easier to look at, and I would just encourage people focus more on ramping up the different behaviors we know, which we're referring to now as essential hygiene action. So changes in water purification, especially point-of-use water purification, prevalence use of VIP latrines and proper disposal of feces to young children, hand washing with soap, including creation of hand washing stations with tippy taps and soap. And also you could include a creation and promotion of protected play areas and other behaviors, because at this point it's a lot easier to measure that, and I don't know anyone that is using some of these other assays as a way to look at something a bit more directly linked to environmental enteropathy.
Maybe I could just add to Tom's response. Part of the MELD study that's being carried out and funded by some Gates money has been looking at a variety of serum and urine markers, biomarkers, mostly proteins and enzymes, that could be measured as an indication of the level of environmental enteropathy or a patient's recovery from that enteropathy. So those are still under discussion. I don't know that we know for certain that those are working, but things like the lactulose mannose assays that have been used in the past are being studied extensively in that research. So we may have some coming up.
All right.
Yeah, just to clarify, actually, that study I was mentioning is from the MELD study, and I'll go ahead and try to paste in a link.
Great. Thanks, Tom. Our next question is, neglected tropical diseases affect both WASH and nutrition. Do NTDs have a role to play in an integrated nutrition WASH strategy?
So I could start with a short answer to that. The answer is yes, most definitely. And that when we think about some of the larger impacts of WASH on nutrition programming, we think of it in three ways. We think of WASH as having an impact on diarrheal disease, having an impact hopefully on the pathogenic environment and any ensuing enteropathy, and thirdly on parasitic diseases, neglected tropical diseases such as worms that have an impact on the absorption of nutrients as well. So we very definitely see all three of those as being important ways that WASH should be integrated into programming to affect nutritional status.
Thanks, Helen. We have another question about the MAL-AD study. Tell me more about this MAL-AD study in Tanzania. Who is doing the research and what stage is it at?
I think I'm going to have to leave that one for Helen because she actually told me about that, and I haven't done as much reading on it. Helen, do you know more about that? And I can look up a website, too.
Yeah, so the MAL-AD study is underway at the moment. There are no results that have been reported formally so far, and I think some of it is being carried out blindly so that the intermediate results don't impact the further on parts of the study. So nothing has been released yet. So in Zimbabwe, there is a SHINE study, which is being carried out by Jean Humphrey, separate from the MAL-AD study that is funded by Gates. But I don't believe either of them have had reports of their results yet.
Thanks, guys. So our next question is, given the additional significant gains achieved by WASH, is USAID making any plans to integrate WASH programming into current nutrition programs?
So the emphatic answer to that is yes, very definitely. And both the water and development strategy and the multi-sectoral education or nutrition strategy both point to that very clearly, that it's important to integrate WASH into the nutrition programs to have the impacts that we hope to see in the future.
And this is Smita, just to add, if you go back to my slides and if you look at the USAID nutrition strategy, they actually do have very specific WASH activities that they name that they're integrating in nutrition activities in the field. And the other way that WASH and nutrition are coming together, I should actually note, is USAID also released a new vision forward for ending preventable maternal and child deaths. This report was released last Wednesday. And nutrition and WASH are actually two of the 6 buckets of intervention that they are that are specifically listed out as interventions for ending preventable maternal and child health as well. So it's all coming together in many different ways.
Our next question is, are there key outcomes in addition to reduction in diarrhea, environmental enteropathy, stunting, and anemia that are being used to evaluate the impact of WASH projects, and to what extent are these outcomes being measured by USAID?
So that is a big question, what exactly is being measured and how they're being measured beyond the list that you just provided. So certainly one of the most important indicators is access, so increasing access to improved water, improved sanitation, and improved hygiene practices. But also there are outcomes that are much more closely linked to health. And those will take longer, I think, to actually come to fruition. And that stunting is not something that is improved on a month-to-month basis. It's in a population level measure that will take much more time. So I think I'd like to defer that answer to the future, but know that it's very important.
Great, thanks, Helen. Our next question is sort of a two-part question, and they ask if there has been any study or interest in investigating the cross-generational physiological changes and how that impacts future generations. And the second is the impact of climate change on these types of cases.
Tom, do you want to say something about the extent to future generations?
You know what, I am not as much up to date on sort of, I know there was discussion at one point about how especially stunting in one generation could lead to stunting in the next, but I would want to research that a bit more to know exactly what we're finding out about it. In the short run, I think it doesn't change much, except that we know that what we can do now with WASH, with some of these other interventions, can actually have an impact later on. But I mean, I don't think it's a large percentage of the stunting we're seeing is because the parents were stunting, if that's what the person asking the question was getting to.
So maybe I can just add to that, that perhaps it has more to do with the health of the mother during pregnancy, in that the first 1,000 days obviously starts in pregnancy before the child is born, and that we know has an impact on stunting outcomes. From a climate change perspective, when we consider WASH programming, certainly climate change impacts how those implementations are carried out, in that if water tables are rising, obviously that impacts how you think about water source and how you think about sanitation and safe disposal of feces. I don't know exactly how that extends into the nutrition space, but certainly from a WASH perspective it is important.
And maybe this is slightly related. I know that with environmental neuropathy, it actually can come on quite quickly, and it can be reversed quite quickly. That they've seen it with Peace Corps volunteers who are often going overseas for only a year or two, and they start having evidence of environmental neuropathy. And on the other side, like Pakistani PhD students that would come to the UK and then suddenly have better WASH would also show a decrease in that over a shorter period of time. So going into those environments, even we as health and nutrition workers might be experiencing some of that by just being exposed to more pathogens.
Our next question is sort of more of a programmatic question. Should WASH practitioners be accountable for improving undernutrition indicators when evaluating the effectiveness of WASH programs?
So that's certainly a valid proposal.
Certainly should. I think it would be a shame not to capture that, basically.
Helen, were you finished or did you want to continue?
So maybe, Jordan, we could leave that with that's a very interesting idea. Certainly something worthy of discussion.
Yes, I agree. Our next question is, are there any examples of WASH and nutrition
we have
programs?
a bit of a lag there, but I'll try to jump in again. Yeah, I think that...
Go ahead, Tom.
Okay, I was saying that I think that given how much WASH can affect nutrition, that it should be something that all WASH practitioners should be capturing, because it's really a shame if that's one of the major impacts of what you're doing and all you're capturing is a possible change in like diarrhea prevalence or child deaths. You're missing the boat in terms of what you might really be bringing out that's one of the most important impacts of the work. So I think it makes sense. Holding them accountable to it, I guess it depends on the focus of the funding source is one thing that would come into play, but I think it does make sense that we should start capturing more of the positive effects of WASH, and that would be one way to do it, just include it in the standard indicators for WASH projects, change in nutritional status.
Great point, Tom. So the next question that we have is, are there any examples of WASH and nutrition programs for adolescent girls and pregnant women?
So that's a great question and would certainly be an interesting study to see. There is a collection of case studies that are being put together in a WASH nutrition book that should be available perhaps next year. I do not recall seeing any case studies that were particularly focused on adolescent girls. Tom, are you aware of anything in that field?
No, I'm not.
Seems like a ripe area for people to get involved in. So this question, I believe, is for Smita. The question is, what is the role of Save the Children in WASH? If you could just give us a picture of how you all are involved.
Well, I think the way through our nutrition programs, we of course are involved by, promoting best practices, hygiene practices, hand washing, safe water, access to safe water. So I'll have to defer to my technical colleagues to give you some specific examples of how we integrate WASH and nutrition, but it certainly, comes under our behavior change and nutrition programs, including practicing safe hygiene and we promoting exclusive breastfeeding and those kinds of practices.
Our next question is, stunting is a great goal, but it's proven difficult for many development projects to demonstrate an impact on stunting rates over short periods of typical programming, so many NGOs are afraid to use it. Can you suggest ways for NGOs to incorporate stunting or height for age Z-scores into monitoring and evaluation strategies without compromising their ability to demonstrate success and thus ensure future funding?
I think it doesn't make a lot of sense to be, of course, measuring height every month or every 3 months. It is something that you're going to have a pretty large sample size to even see a change in it over a 1-year period. I think what's more important is to say include that stunting indicator for baseline and final and yearly if it's required by the donor, but instead be measuring the behaviors themselves, the WASH behaviors, the nutrition behaviors, and what I often promote is using lot quality assurance sampling. There's a great example of using that within a care group project on the FSN network website where you're doing small sample surveys in each district to look at how are these changes in behaviors changing. Because if you can demonstrate those large changes in the percentage of people purifying the water, doing the essential nutrition actions, the other essential hygiene actions, then I think you're going to get at changes in stunting. And as we've said, even with our general focus on nutritional interventions, you're only going to get at a possible 20% reduction, even if you get to 90% coverage. So that means new things. That means focusing a lot heavier probably on WASH than we have in the past. And also some things like maternal depression, which I have a question from other panelists when we have a chance for it related to that.
Tom, if you want to go ahead and ask that question, now would be a fine time.
Sure. So there was a meta-analysis done by Pamela Sirkan. It was in the WHO Bulletin back in 2013. And they found that, she found that elimination of maternal depression could reduce malnutrition by 23 to 29% worldwide. And a previous randomized control trial, Paul Bolton is one of the people that worked on that, found that depression could be reduced by 93% in less than 3 months in a developing country. This in case it was in Uganda, without medications. So it's easy to see the possible mechanism with that, since mood can have such an impact on people's behavior. And I'm wondering, is there a reason that reduction of depression, that we're not talking about that more, and it's not a part of this strategy? Is it just that people felt that there wasn't enough evidence yet to begin promoting that we work on things like maternal depression as part of this strategy? Or if not, why aren't we doing more with this?
So Tom, I think that's a great question. It came up recently also in a discussion about improving child development. And certainly depression could be an interesting player in child development as well as in nutrition. And perhaps we need a more significant link between the evidence all the way through to programs to actually demonstrate what the effect, the tangible effect might be. So I'm not familiar with this work from 2013. It would be interesting to see the evidence base that led to those high percentages that you just reported. but it's certainly not something that I had seen before. So that's an interesting, perhaps sort of new way of thinking about these issues.
Okay, our next question.
Smita, do you want to comment on that as something that might have come up in discussion?
Go ahead, Smita, if you want to comment.
Oh, no, go ahead with the next question.
Okay, so Tom, the next question is for you. Can you please elaborate on the link between environmental enteropathy and cardiovascular disease later in life, as well as the link between pneumonia and environmental enteropathy? The request is specifically in layman's terms.
Okay. I would say let me start with pneumonia. This was from a study that Luby and colleagues did in the Lancet. They basically looked at the incidence of pneumonia and found that it was markedly lower among children, and that either where they'd done an intervention to promote either plain soap or antibacterial soap than in control groups. Pneumonia was reduced by 50%. With 95% confidence intervals around that figure, from about somewhere between -34 and -65% reduction in pneumonia incidence by regularly doing hand washing with soap. So that's something that we have just not talked about enough. I think that we often think of hand washing with soap primarily focused on diarrhea, and now we're knowing that it affects growth as well. But it does affect pneumonia, which is one of the largest killers of children around the world. And I'm sorry, the other one was around, what was the other part of the question?
Cardiovascular disease and environmental enteropathy.
Yeah, I think part of it is we've known for a while that children who are stunted, that later in life we've seen more problems with diabetes, cardiovascular disease, some of the diseases of more developed countries, that if children survive through that later in life, somehow breaking down this mechanism, and that mechanisms that lead to poor growth early on lead to the same problems that we see in more developed countries later on, like diabetes, cardiovascular disease. And I don't know that we totally understand why that's happening, but it is interesting that they are finding in the United States, when they looked at disruption of microbiomes, so that when children who receive more antibiotics when they're younger are more likely later to be obese. And they believe it's because we're killing off some of the bacteria, and then other bacteria kind of take over and lead to like changes in how we metabolize foods. And also they found associations with that and eczema and a couple of other diseases as well. So it's not well understood, I think, exactly why this is happening. But with this new focus on microbiomes, sort of all the different bacteria that a child and an adult has in their gut and how they change when we do things like either use of antibiotics and also C-sections, where children aren't exposed to the bacteria in the vagina, they can end up with different bacteria living on them and in them, and that seems to have some impact on how they are metabolizing food.
Great. The next question is on the same sort of topic of environmental enteropathy. We have a request to discuss aflatoxins and its link with stunting. There's a lot of research on this link, but perhaps environmental enteropathy is actually causing the stunting and not aflatoxins. So if anyone has any comments on that link, that would be great.
So maybe I can start and Tom can follow. I think there's been some interesting work that shows that when you experience environmental enteropathy, you increase the permeability of the gut. And that increase in permeability could increase the level of aflatoxin that is absorbed by the body, so that you would experience a higher dose of aflatoxin when you have enteropathic responses. So that could increase the susceptibility to aflatoxin when environmental enteropathy is present. I'm not sure of the claim that it's entirely about enteropathy and not really about the aflatoxin, because even in locations where there's very little enteropathy, I think aflatoxin is still considered problematic. But perhaps, Tom, if you want to follow with some of your experience.
No, I would agree. That's about all I know. I don't think we know enough about this this area. We know it's not good for kids to be getting aflatoxin into their systems, and we do know that environmental enteropathy leads to a more permeable gut. But beyond that, I don't think we can say very much at this point.
The next question is there any direct evidence of effects of lack of access to WASH services on fetal growth during pregnancy?
So I think the answer is yes, and I would refer you to the 1,000 Days Network for evidence of that discussion, of the importance of the health of the mother during pregnancy and how that influences nutrition later.
This is Smita, and I think it just goes back to not just focusing not just focusing on child nutrition, but as Helen just said, the importance of maternal nutrition, and I would think integrating some of the safe best practices in water sanitation and hygiene, particularly access to safe water and safe hygiene practices, and all of that I think needs to be integrated into the maternal nutrition piece. I was just trying to look up if there has been any impact studies. I think that's a good question. I don't think, at least Save the Children, we didn't have anything on our in our database on that specifically, but all to say is that I think, to begin integrating WASH right in that 1,000 days period, I think is key.
Yeah, and I did remember one other piece connected to aflatoxins. Some studies have been finding that aflatoxins, together with some of the other mycotoxins that you can find on maize and groundnuts, for example, can bring about intestinal damage that's very similar to environmental enteropathy. So once again, that they can have that same effect in terms of making the gut more permeable. That can lead to this chronic immune activation. That can lead to poor growth. So they're working in a similar way. It's not like that one is we thought that aflatoxins was the problem. It was actually environmental enteropathy, but they both have a similar effect on the gut. So we need to be concerned about both.
This next question is a great question that we could probably do a whole webinar on by itself. It is, how does integrating WASH programming into current nutrition programs look in practice? Will the scope of work of current programs be expanded, and where will the funding come from? So Helen or Smita, if you want to answer.
Smita, do you want to start from sort of a big brush perspective?
Yes, I mean, I think first of all, in the funding piece of it, that's why it's important to increase, and I think this came from a meeting, in fact, that our CEOs, the NGO community CEOs, have been meeting with Raj Shah several times on the nutrition strategy. And when the funding piece came up, how do we make this truly multi-sectoral, and in this case particularly, how do you scale up WASH interventions and nutrition interventions? The funding piece of it is, where is the funding coming from? It's coming from across all USAID programs and budget, and so first piece is to really get the funding increased across the board in the international affairs account, across development assistance, across child health, across nutrition, maternal and child health, and across nutrition, and even outside of the USAID development assistance program. So I think, and that's why we need that budget, that transparent, comprehensive budget, to see how we can leverage and maximize other accounts that are out there, so we can identify ways to scale up nutrition-sensitive interventions in this tight budgetary environment. And so I think, that's the funding piece of it. Helen, I don't know if you wanted to tackle the programmatic piece of it.
Yeah, so maybe I can just add to that discussion a little bit. So I would agree with what Smita has said, that it would be very interesting to be able to think about how to jointly program WASH into nutrition programs and perhaps use existing funding. I don't know of any new funding that becomes available for this, but use existing funding in ways in which we're able to integrate the outcome of those projects. Some of the specific implementation detail, things that have actually been carried out in projects, include things like coordinated engagement with governments, coordinated field visits when you actually go into a community, joint promotion of behavior messages and WASH and nutrition actions, using food demonstrations to describe both nutritional aspects and WASH aspects of food preparation. In ag programs, and perhaps this is one of the most notable changes in how people think about some of their WASH programming now, is the idea that we not only need to decrease human waste, but also animal waste in these environments so that we decrease the ingestion of pathogens from animal waste and from soil. So I think there's a slow evolution where people are beginning to think more broadly about the intervention space. And as Tom said earlier, the important part isn't necessarily just measurement of did you decrease stunting, but to think about these encompassing new implementations that are more comprehensive than maybe they once were, and think about how successfully those are being scaled.
I just said one of the things from the Sean studies I thought that was fascinating. When they started looking, they were swiping different things that children put in their mouth, and swiping in the kitchen, testing for bacterial levels, especially E. coli. And one thing that just blew it out of the water was children were picking up and eating chicken feces, which were loaded with E. coli. And when you saw the things they could work on, you realized keeping animals and children separated, especially animal feces and children separated, was just hugely important. So I think that's something we really have not really devoted as much time to, and one reason Sean was saying having this protected play space with this lofty goal of not having children consuming feces of animals or other people anytime during the first 5 years of life. That's what they're going for, and we should be trying to make that happen. And just thinking, and when we come into a new area, it's not just about ramping up a couple of interventions, but how can we really help make sure that children are not getting this contamination from whatever possible source there is in the environment.
The next question is sort of a follow-on to that. We have a lot of examples, or a lot of the research is mostly focused on the 1,000 days period. One of our participants is wondering if there are any recommendations for integrating WASH and nutrition for older children.
So maybe I would just start by saying many of the same interventions are appropriate as children pass out of those first 1,000 days. But one reason for focusing on those first 1,000 days is that period seems to have a much greater impact on growth and development for the rest of those children's lives. And so the impact is so great in the first 1,000 days that that has been a point of focus, but not to diminish the value of continuing these same interventions as children pass beyond those 1,000 days.
The next question is back to environmental enteropathy. Tom mentioned that enteropathy is reversible. They want to know, what is the time frame we're talking about? Is it weeks or months or years that it takes to reverse?
Some of the studies that I was talking about, it sounded like that it would reverse within 4 to 6 months. I could look that up and see if there's any more on reversal in children, but it's often getting people out of the environment is when they've actually been able to see that it reversed. So for our purposes, I don't know how helpful that is to know if you ship people from Pakistan to the UK and give them excellent wash that it can reverse pretty quickly. The real question for us is how quickly can we get it to reverse in the settings where we're working, and I'm not sure of that. And I think part of the problem is that we have to be firing on all pistons. We need to make sure water purification is there, proper disposal of infant and child feces, latrines. There are a number of things we need to be working on all at once to reverse this, and I haven't seen these studies that really showed that they were able to get rid of the majority of it, and then after that, how fast would it improve. But I think even when you dramatically improve wash, you still can see that it can take months at least.
Our next question is about the targeting of these integrated programs. Does WASH nutrition programming need to be done as a population-wide approach or high-risk population approach, such as specifically targeted to the poorest of the poor?
So perhaps as a general answer to that question, in populations where there are poor WASH practices, then it probably makes sense to carry out integrated programming. Whether or not those are considered the lowest quintile or not the lowest quintile, I think it's more dependent on the presence of good quality WASH practices.
Yeah, also when you think about something like Ascaris that can lay 1 million eggs every day, I think you really, taking a targeted approach doesn't make as much sense since one family's practices can influence so many other families. I think having a broader-based approach makes a lot more sense.
The next question is there any link between WASH and perinatal mortality? And if so, can you elaborate on WASH strategies for perinatal mortality?
I'll see if I can find the citation. I remember a very impressive study that was in Nepal. It was not an intervention study. It was more showing associations, but there was a huge association between hand washing with soap and neonatal mortality, something like 40% less mortality amongst caregivers who wash their hands with soap, and even if you added in having the midwife or whoever attended the birth washing their hands, that seemed to help as well. I'll see if I can find that. It wasn't, the best study since it was more showing an association versus like an intervention trial. But there definitely have been studies that point to this having a big impact.
The next question is about the use of indicators to measure WASH impact. It's very hard to measure the WASH impact just by relating it to diarrhea cases, especially if people don't go to health centers every time they have diarrheal episodes. And diarrhea could also be caused by multiple factors. Is there another indicator you could use to measure WASH impact?
So the answer is yes, probably, but it's not trivial to measure the impact of WASH, as I'm sure some of you know. So, for example, there are diarrheal indicators that are much better as measured as population-based indicators, not changes in a small number of people. And so DHS measurement of diarrhea over the course of a large population would be much more meaningful. There are other health status indicators, wasting, stunting, underweight, then other descriptions of diarrhea. Oftentimes we measure the use of good practices, so the percentage of nutrition staff who know the critical times for hand washing, or the percentage of households that are practicing safe disposal of child feces. And although those are not measuring health impact, we expect them to be correlated with health impact later. So in answer to your question, it's tricky to come up with the ideal indicator, and I think that's why we often look at practices And health outcomes are difficult to measure over short periods of time and in small groups, and are much better indicators for population-based studies.
We have on our webinar Save the Children's WASH advisor, who will be able to answer the question about Save's WASH work, especially related to nutrition and WASH. He says, we have 2 large nutrition projects, 45 to 50 million people in Nepal and Ethiopia, that have now added WASH components. They have a 3rd project in Cambodia that's about to start, which in its initial design is testing stunting as an outcome of WASH and nutrition intervention. In addition, SAVE is the WASH lead on a newly awarded USAID flagship MNCH health project, the Maternal and Child Survival Project, which is the follow-up to MCHIP. In short, on the technical side, they are looking at household-level hardware interventions, focusing on households with pregnant mothers and under 2s, and integrated communication plans. We are also tying in private sector interventions for WASH products and services like latrines, hand washing devices, water filters, and others. Added to the private sector pieces, their communications efforts look to integrate commercial marketing. So thank you, Ian, for filling in those gaps. We have another question. This person says they are afraid the use of WASH could be masking effects of sanitation on nutrition. Are there studies which look at sanitation and nutrition alone?
So WASH does include sanitation, right? It's improvements to water safety, sanitation, and hygiene. But if we were to take out just the sanitation piece, which is of course of great importance to this discussion about enteropathy and nutrition, there is the work of Dean Spears. He did some work looking at large-scale data sets from DHS across India and was able to show correlations between toilets and stunting. But I don't know of anything that points directly yet to the impact of sanitation on stunting and other issues related to nutrition, although I believe it is part of the outcome we expect from the WASH benefits trial that is underway currently in Kenya and Bangladesh.
Yeah, I would agree. Sanitation, when I think of if you had to choose one thing to work on there, number one, don't. Try to work on water, sanitation, hygiene. But I think sanitation is one of the largest pieces of this that we've probably been ignoring more. When we did local determinants of malnutrition studies when I worked with Food for the Hungry in Mozambique, Ethiopia, other countries, and I remember finding some of the biggest associations we found with malnutrition. In Ethiopia, it was more how do you dispose of your child's feces, so the sanitation piece. Where in Mozambique, it was do you purify your, or what do you do to treat your water? And women who had purified their water had much healthier kids, so we put a real focus there on water purification. So I think it can vary by area, but sanitation is probably one of the pieces that we've spent so much time talking about latrines, which is really not the only thing we should be doing when we're dealing with kids who are much younger. It's that proper disposal of feces in addition to use of VIP latrines for kids that are a bit older.
Jordan, would you mind if we took a step back for a moment and talked about the intergenerational question about intergenerational effects of stunting?
Sure, that would be great.
So I just wanted to bring forward input that we got from one of our listeners today, that there's actually quite a lot of evidence that pre-pregnancy maternal stunting is not just correlated, but is actually causal in child stunting. A big factor is due to the restricted uterine space and a host of other factors from a stunted parent. And there's an interesting article here, as well as obviously the 2008 Lancet series on nutrition. But there's an additional article that I just want to bring your attention to. And let me see if I can give it to you in some way other than DOI, because that's not a very convenient way to discuss this. It's called Long-Term Consequences of Stunting in Early Life, and it was published by Catherine Dewey, and it's in Maternal and Child Nutrition, Volume 7 from 2011. And so there's an entire article discussing the effect of maternal health on stunting. So thanks, Jordan, for that step back.
You're welcome, and thanks for sharing that. We will be sending out a list of resources that have been mentioned in this presentation, so we'll be sure to include that as one of those resources. I believe we probably have time for one last question, and this question is about stunting and environmental enteropathy. Are there any sources or studies you know of that tell us the proportion of stunting that can be attributed to environmental enteropathy versus diarrhea?
Well, there's an overlap there, obviously, but as I was saying before, there have been enough studies that show that that diarrhea didn't seem to be having that much effect on growth that we've started concentrating instead on environmental enteropathy, which seems to be consistently connected to growth. Now, the actual percentage in a given population, I think that could vary greatly, whether you're seeing both environmental enteropathy and diarrhea, how much association you would see with child growth. But I think it's not something that you'll have the same answer for every country, but some of the same interventions that target one also help the other. So our real focus just needs to be on increasing those interventions and not looking at the outcome of whether we've achieved something by just looking at diarrhea. I think it's going to take time until we have some readily available ways to look at, for example, urine tests that Helen had brought up earlier can help you know if we're doing something with environmental enteropathy. But in the meantime, I think just focusing on those behaviors themselves, essential hygiene actions, is what we should be doing.
Great, and I think we have answered all the questions and are out of time. So thank you so much, Helen, Tom, and Smita, for your presentations, and thank you everyone for joining us for this important conversation. We do invite you to continue the conversation on Washington Nutrition, especially on the community of practice that Helen presented. Thank you very much.